Hello and welcome back. This video provides a brief overview of Lesson 8, Vestibular Rehabilitation Therapy, or VRT. In this lesson, we talk about the indications of vestibular rehab therapy, which may be a hypofunction, decreased sensory organization processing, BPPV, Meniere's. Yes, Meniere's can be considered stable if someone isn't fluctuating between the spells. So some patients will have persisting symptoms in between those more severe spells, and that's when they're candidates for therapy. And the same for vestibular migraine. It's just that migraine falls under neurological. So in that next category, it may also include Parkinson's, MS, MDDS also falls under neurological. 3PD is considered neurotologic, both vestibular and neurology. So we're going to bump that to another category. Post-concussion could be under neurological since it's considered brain injury, but we address this separately as persisting symptoms post-concussion. This is where we talk about profiles, as if vestibular, visual, headache, migraine, it's oftentimes a combination of those. There's also a school of thought that concussion may not always be a brain thing, but it's related to symptoms due to a whiplash-associated disorder. The category of FND or FMD, that's functional neurologic. That's the overarching category, and then a movement disorder can fall under that. These are conditions that result in functional impairments that significantly interfere with one's quality of life, their ability to work, carry out activities of daily living, although most diagnostic tests are normal, and 3PD could fall into this category. Fall risk, the prevalence and consequences of falls remain a concern. Studies indicate we have significantly improved our identification of risk factors, but we have not seen a significant reduction in the number of falls that occur. Patients will often express their concerns of falling due to the fear of breaking a hip, which is justifiable. What many do not realize is that falls are the most common cause of concussion. We have visual motion sensitivity. This is also known as visually induced dizziness, or dizziness due to complex visual environments. And we've added long COVID. Dizziness may be present due to a subsequent inner ear infection related to COVID, BPPV, or autonomic dysfunction, or a combination of all of these conditions. So what are the components of a vestibular rehab program? Well, in the image to the left, the activities in the middle are purposely in black to represent the most common activities associated with VRT. This is canalith repositioning maneuvers, or CRMs, VOR training, balance, gait training, fall prevention strategies, which also include strengthening flexibility and/or aerobic activities, exposure to optokinetic stimulation for visually induced dizziness, and education is a key component to a successful program. The other words you see are in a gray-colored font. At the top of the image, you'll find the ocular motor activities. Current CPGs, or clinical practice guidelines, specifically note that ocular motor exercises are not part of VRT. Now, this is accurate because those activities are related to the visual system, not the vestibular system. However, the vestibular, visual, and neck share intricate and complex neural pathways. Thus, you will most likely be including these activities, or already do, into your patient's care plan. In other words, vestibular exercises will be a part of your treatment plan. Other helpful interventions include lifestyle behavior changes, sleep, diet, stress management, may include dry needling, manual therapies. Some of you may want to add facial paralysis retraining. Working in this patient population, you may see patients with Bell's palsy or facial paralysis post-acoustic neuroma surgery. And certainly we commonly make referrals to other providers. And then you may be thinking of just other options that you integrate into your treatment plans that aren't shown on the image. We'll talk about the principles of vestibular rehab, which include adaptation, habituation, or substitution. Adaptation is to train remaining function of the vestibular system to work better. So these are long-term improvements by modifying VOR gain and best for reduced vestibular function. Habituation is desensitization to a provoking stimuli. Our goal here is to reduce the neurological response to a noxious stimulus through repetition of the stimulus, which is done through gradual dosing. And then substitution. You may also hear this called compensation, but it's training to utilize alternative systems for function, maybe from the visual system, the somatosensory system, specifically cervical proprioception. This is best for complete vestibular loss. If you notice, the title of the slide notes shift happens. The meaning on this slide is to highlight the shift in theories on VOR adaptation exercises. More current research shows that the standard VOR times 1 training as defined by the CPGs do not result in adaptation, although we frequently refer to VOR exercises as adaptation exercises. I've been in this space for 30 years and have seen standard VOR exercises result in subjective and objective improvements. However, it appears this is not due to adaptation, as has been discussed in the literature, but due to habituation. In this lesson, we'll discuss novel techniques that have shown to change the VOR gain, as well as treatment activities that result in the most optimal outcomes. This lesson also covers guidelines and key concepts. We don't discuss protocols, although an exception of that might be the DIE protocol for MDDS. And even in that known protocol, we customize it and modify it to our patients. One of the challenges about rehab is that we know we learn through repeated exposure to error messages, but it can't be too big or it's too difficult to learn from. The other thing is we can't learn if our fight, flight, or freeze system is on. And in this patient population, much like in chronic pain, we see our patients in this elevated sympathetic nervous system response. We must implement activities that are specific to the patient. What motivates them? What is enjoyable to them? What mimics their lifestyle and is designed around their goals? Customization is key, as is ongoing education throughout the treatment plan and even beyond. Integrating these concepts into your program can increase adherence and long-term outcomes. Initially, we'll start with small, successful tasks that are in the patient's conscious. Ultimately, the goal is to move more into their subconscious, especially in regards to balance strategies or being able to properly suppress sensory inputs. When we think of rehab, we think of activities that facilitate use of sensory inputs, adding a vestibular stimulus, adding a visual stimulus. Many of your patients, however, will have difficulty with suppressing stimulation. This can result in activating fight, flight, or freeze. Remember, we can't learn in this state. This doesn't mean you avoid all these activities, but the treatment plan may need modifications. Maybe it's VOR in the dark or VOR using support around the neck, integrating grounding techniques such as breathing or wearing weights, keeping their feet on the ground, doing more closed chain activities. As clinicians, we are often driven to gather as much information as possible, especially about symptoms. During the rehab process, however, we move more away from asking the patient to keep a journal or consistently report their symptoms. Instead, we monitor their recovery. In our clinic, we use the 5-minute rule. I know other clinicians who use the 3-minute rule, while others use the 20-minute rule, meaning how long do your symptoms last after the stimulus? So we're less concerned about causing symptoms and most focused on how quickly does someone recover. This video was a bit longer, but there's so much to talk about in treatment, and it's always so much fun to learn what activities clinicians are using. I learn something every single time we do this course, and so will you. Stay tuned for the next video for Lesson 9, the role of the neck in dizziness.